Hel- Hello and welcome to Cromwell Hospital's latest online health talk on endometriosis and intimacy. Please ask your questions using our chat function. Our panel will try and answer as many questions as possible before the end of the webinar. This webinar is being recorded and you will be sent the recording tomorrow morning. I'd now like to welcome Mr. Amer Raza, consultant gynecologist, Liliana Jorovich, pelvic health physiotherapist, and Mitty Ratch, clinical lead pelvic health practitioner and non-medical independent prescriber, your panel for this online talk.
Thank you very much, Addy, for introducing us, and good evening to everyone. This is our last webinar of the year, actually. We have gone through 6 webinars this year, which have been very well attended, and also lots of interesting discussions and questions came out as well. So we are now presenting to the last of the webinars for this year, but on a very important topic, which is intimacy and endometriosis. And I'm so pleased and happy that I've joined by 2 wonderful colleagues, Mitty and Liliana, who are absolutely expert in their fields and will be telling us how can we help everyone with this very difficult issue. Now, what I'm going to do for the next 6 to 7 minutes, I'm going to take you through a journey of endometriosis, very specific to dyspareunia. It will evoke a lot of questions. Possibly it will also explain some of the questions you have in your mind as well. At the end of the presentation, I have a video to show you from inside. Please switch off the computer if you are just switch on the screen. If you don't want to watch video, I will warn you before I show you the video again, because I'm sure some people won't like to see what's inside the abdomen, but it's a video of the robotic surgery of endometriosis inside. So I'll share my screen now, and we'll share the video. Here we go. I hope my technology works. Share. So I hope all of you can see. And so can all of you see my screen, please?
Yes, we can see your screen. Thank you.
Thank you very much. Thank you. Now, Cromwell Hospital is one of the major centers of endometriosis. We do the most number of cases in the year, in any year of endometriosis since 2024. We are also very happy that from not only laparoscopic, we moved on to robotic endometriosis surgery. And this year has been a big change that we went on from multi-port robotics to single-port robotics, which means that we make only small hole in the belly button and we can do the whole operation from that small hole. So technology is moving, things are moving, and we're all moving in the right direction. And obviously in Cromwell Hospital, we keep working hard to not only do the surgeries, but also do these webinars to help with the topics as well. So I will not go into detail, but we all know that huge number of women suffer with endometriosis, 250 million women worldwide. Sadly, there's no diagnostic one test like I can do a blood test and say there are some new things that have come in the market, but we're not certain yet of their benefits in terms of their costs. There's no cure for the disease. So really we go from symptom management to whatever issue is, from fertility to dyspareunia, as we will be discussing today. The issue of endometriosis can go all the way from quality of life to fertility, which I'm sure many of you will know yourself or your friends, family who will be suffering with this problem. It's a disease which doesn't restrict itself from one organ. It rather goes outside the uterus and can involve ovaries, uterus, fallopian tubes, rectum, bladder, even go up to diaphragm and umbilicus. So quite a multi-organ disease, hence a multidisciplinary care is needed for these kind of severe endometriosis cases. And we all know that from a normal life to depression, anxiety, it can have a serious impact. And the sad thing has been that there has been a delayed diagnosis of 7 to 9 years before we know it's endometriosis, but these things are getting better. That's the good news. Things are getting better, and doctors are getting better in diagnosing endometriosis in their clinic with good history taking, examination, and ultrasound scan. However, challenge still remains. Fertility is a big issue when it comes to endometriosis. 20% of women will suffer with it, and obviously lack of awareness and lack of research is a big problem. So when it comes to endometriosis, I will still say there's an etiological confusion that we don't know why it happens, and that leads to obviously no fixed treatment option as well. I will just I will just run through the slides. I don't think we need to go through them, but basically you all know that endometriotic glandular cells are inside the uterine cavity. These cells leak outside or grow outside due to a number of theories. It could be genetic reason, it could be immunological reason, it could be inflammatory, it could be embryological, like when we are born, some of the cells from the inside of the uterus are just spilled outside and they remain outside, and when we become 12, 13, start to have their periods, these glandular cells become active, lead to adhesions and scarring inside the abdomen, and that leads to pelvic pain and number of those symptoms. And again, there are many theories to proceed, but I will not go into that detail. And these different pictures show how there are many mechanisms have been described to explain that why endometriosis starts to grow outside the uterus in the pelvis, just like any cancer cells, but not cancer, but cancer like cancer cell. It has its own blood supply, it gets its own nerve supply, and that allows it to grow from a tiny small spot to a very big lesion, which we call frozen pelvis or deep infiltrating endometriosis involving every organ. There's a huge inflammatory response goes on in the body with all these cells, which again leads to a number of issues as well, which I will just move on. And this takes me to this diagram and picture as well, just to give you an idea what it looks like from outside. If you see from outside, then it's vagina, we have muscles, which will go into the detail later. And if you look from inside the abdomen, then you see on top is a uterus, just is the back of the cervix, and this back of the vagina in this area. This arch you see, we call this arch uterosacral ligament. These are one ligament on the left side, that's the right side, and this is the torus of the uterus. So this is the from inside of the body. If you just go the other side outside, then actually is the vagina. So this torus of the uterus and these two ligaments are the most important thing. We'll be talking about it in terms of painful intercourse, and there are other structures as well. Now, these uterosacral ligament, just keep remembering these two ligaments I showed you, left side, and that's the right where my arrow is now. These two uterosacral ligaments are one of the most densely innervated tissues inside the body. They have fibers in them, autonomic fibers, sympathetic, parasympathetic, we call them, which means they have a nerve sensation going from the uterosacral ligament all the way to the brain, and the brain coming back to the uterosacral ligament. And this way they communicate very actively with the brain because of this supply. We also know that these uterosacral ligaments have many efferent fibers, or sensory fibers as well. And these fibers arise from the vagina, cervix, uterus, and behind the vagina in the recto-vaginal space, what we call it, or in front of the bowel. And these sensory efferent fibers also go to the brain as well to convey, to message the pain sensation. The other thing that we have found also in uterosacral ligaments, that they have nociceptors. These nociceptors are very sensitive tissues there in this area, which detect the stretch, pressure, inflammation. Anything which stretches and pulls this uterosacral ligament, nociceptor will pick that up and relay to the brain to react to that thing as well. So the message is that these uterosacral ligament are very sensitive structures in our body and very highly densely innervated structures from the nerves as well. Now, what happens that this structure, this four structure I showed you, they can go through inflammation, they can go through fibrosis and scarring, nerve trapping, tethering of the uterus and pelvic organ. So when endometriosis start to happen in these uterosacral ligament, then we see all these four colors of disease. That endometriosis, we talked about why it happens, inflammation. This makes this uterosacral ligament thick and inflamed. This inflammation then leads to fibrosis and scarring. Things become very hard. Now, we already said that this area is full of nerves. These nerves then gets entrapped, and this innervation, a new innervation means new nerves start to develop with this inflammation, and this makes things much worse in terms of pain. And when next step is this fibrosis and scarring leads to tethering of the uterus and pelvic organ, that just makes the whole thing very difficult. So this uterosacral ligament endometriosis can have this four impact from inflammation to tethering, which leads to number of symptoms. The question then can be asked that how this pain travels from the vagina and where it travels to. So just briefly, very briefly, we don't go into the detail, that from vagina and these nerves convey the message to the pelvic spinal plexus, which are the collection of nerves. From there, the messaging goes to spinal cord in our vertebrae, and from there it goes up to brain. But there are many different ways these information travel from the vagina and cervix and deep pelvis structure to brain. It goes through what we call in our language pelvic splanchnic nerves, S2 and S4. They are actually very deep in the pelvis, where I showed you uterosacral ligament. If I just go deeper, that's exactly where the pelvic splanchnic nerves will be. Hypogastric nerve, again, same thing. Same area I showed you uterosacral ligament. If I just quickly go back, then again, these nerves are exactly in this area where you see uterosacral ligament. These nerves lie in that area. Then pudendal nerve branches. This is the nerve further down toward the vagina. But inflammation from endometriosis sensitizes these nerves up there and lowering the pain threshold. That's when the pain starts to happen. So this is the pathway, how pain travels from the pelvis right up to the brain as well. But then again, there's something else happens as well. That this inflammation of the nerves inside the abdomen from endometriosis leads to what we call deep dyspareunia, which means pain on deep penetration. And this pain in deep penetration happens because these uterosacral ligaments are stretched, pulled, moved, they are inflamed, they send the nerves to the brain, and then pain comes. But then the question comes, why the pain then turns into superficial dyspareunia? We use different words like vaginismus. It's because there's something in brain goes on what we call protective pelvic floor guarding. With repeated painful intercourse, the body creates a reflex guarding response. And what happens? That is muscles like levator nerve, which my colleagues will explain to you more later on, they become hypertonic, they become very tense. And this tense leads to further muscles being very tight, and entry into the vagina becomes very painful. And people will describe in the clinic as burning pain, stinging pain, stretching pain. So you can see now that that inflammation of uterosacral ligament inside the pelvis leads to, first of all, deep dyspareunia, pain on deep penetration. And then this pain then goes into this protective pelvic floor guarding, which then leads to superficial dyspareunia. And then it almost becomes impossible to cope with the pain either way. Now, brain also is very active when it comes to these things, and there are many ways it works to make things worse. Actually, the brain can predict the pain when it happens many times. The brain knows this event is going to be painful, so brain goes through a different protective mechanism. It thinks that any penetration will be equivalent to severe pain. So even when there is no immediate deep stimulus, the brain produces anticipatory contractions. The muscles contract of the outer vagina, which obviously makes the penetration very difficult. Superficial muscles will go into spasm. Vagina will become dry. There will be no lubrication. Increased sympathetic tone will lead to further contraction of the muscles. And all these things are linked to from deep dyspareunia to superficial and vaginismus. So this can give you some idea that why the pain will become so bad that even the simple penetration will not be possible, because brain is predicting and is responding to that pain stimulus, but it is getting from uterosacral ligament. Now I'm showing the video. If you don't want to see the screen, please switch off the video, and I'm going to start next. Now I'll explain to you exactly what happens. So video starting next. So this is exactly what you see when I say uterosacral ligament. You remember that picture? This is the uterosacral ligament, and you see what's happening here. There's a big lump of black endometriosis growing on the uterosacral ligament. These nerves, what we taught inferior hypogastric nerve, are running exactly where you see my arrow, and that's where the splanchnic nerves is. So this is a very rich area in terms of endometriosis, and I will just relate it with the endometriosis means I've just related with the endometriosis now in a second. I'll go forward so we save time. So this is exactly the black lesion of endometriosis, what we call torus of the uterus. Here's endometriosis on the left side, on the right side, uterus is on the top, and the rectum, the yellow stuff you see on the back. So our rectum is tethered with this nodule. So what we're doing now, my assistant is pushing a probe in the rectum now to push it forward. You see it's moving forward now. You can see the rectum is all involved with this uterosacral ligament and a big lump of nodule. And this is completely supplied with lots of nerves around it, which communicate with the pain. Now, obviously, I'm a surgeon. I will do just one part of surgery, which means I will remove all this abnormal disease. So we're doing a multi-port robotic surgery in this case now. And this abnormal peritoneum you've seen, we are simply going to excise it. And here we have a suction system, and we will remove. Our theory is that when we remove this scarring abnormality from the uterosacral ligament, then the tissues open up a bit, they relax more, the contraction goes, it relaxes the nerves, And this area then becomes less painful and less tender if we operate. But if we operate, that's just one part of story. Here we are dissecting the deep plane because nerves are underneath. So what we say in our language, we do a nerve sparing surgery to make sure we don't cause any damage to nerves. So when nerves have been pulled on one side, we'll go on to excise and remove all this black patch, like you see as well, and remove it. Once we remove this black disease, then symptoms will get better. And obviously this, but this again, I said, is one part of that thing. People will still continue to have symptoms, and then that's the time when we have treated the disease surgically. But because pain still continues, and my colleague will explain to you, we need more things to do, because surgery alone will never solve the problem. We need to go one step further to help the nerves, help the muscles. So I'll just go straight to Liliana now to take it from there and tell us more about, from her perspective, how you will deal with the situation. Are you muted? I can't hear it.
Oh, sorry about that. Good evening again, everyone, and thank you, Mr. Raza. I'm Liliana, pelvic health physiotherapist at Cromwell. Well, I'm going actually to go briefly through physiotherapy management following surgery for endometriosis, and like what to expect when you come as a patient, and what we do, what we talk about, and what are the ways that we can help and further sort of improve on condition that was operated on. So if you don't mind, I'm going to read through my shortcuts, but obviously I'll be absolutely happy to expand on anything that you would like to discuss later on through the questions and answers. So all the surgery, as Mr. Raza said, all the surgery is first line treatment, and pharmacological interventions are first line of treatment for endometriosis. 20 to 40% of women have symptoms persist following that treatment. Furthermore, the extent of endometriosis lesion is known not to necessarily correlate with women's pain. So chronic endometriosis pain is classified in like chronic primary pain, which comes from visceral and musculoskeletal pain, and also chronic secondary pain, which comes from post-surgery, post-traumatic, neuropathic, visceral, and musculoskeletal pain. So as we know, endometriosis pain doesn't only come from the lesions, but also from long-standing pain protective mechanism and subsequent changes that follow that. So once when surgery is done, what we usually have, most common symptoms that patients still come with are pelvic pain, probably due to scar tissues and adhesions, muscle guarding tension as response to long chronic pain, leading to vaginismus in dyspareunia, bowel and bladder dysfunction affected by pelvic inflammation, surgery, neural sensitivity, and altered movements and postural alignments. So for endometriosis patients, surgery is definitely a milestone, and it's really beginning of the chapter of recovery and rehabilitation. So it is absolutely crucial to know that once when surgery is done, that if there is some residual pain there, and with majority of patients there is still, it's just really time and rehabilitation that has to be sort of applied to reduce that further. Because obviously surgery could not really get all that diminished. So first outpatient appointment usually is recommended 6 weeks post-operatively. And as any physiotherapist, but with pelvic, we are trying to restore function and mobility post-surgery. We also try and assess the pelvic floor, looking for scars, adhesions, neuromuscular pattern that, if not addressed, could interfere with normal bladder, bowel, or sexual dysfunctions. The assessment is consisting of subjective and objective part. With objective part, we usually do quality of life questionnaire. We do female sexual function index with patients who have a severe dyspareunia. And we do patient-specific functional scale, so really looking at functional things that are not basically that are complaints, and numerical pain rating scale. We do musculoskeletal assessment if needed with musculoskeletal physiotherapist, if there is sort of musculoskeletal obvious involvement. With pelvic floor assessment, we do mainly pelvic floor muscle function. We look for power of muscle of pelvic floor muscles. We do for ability to activate and relax and mind-body synchronization. We look for presence of trigger points, and we try to identify specific individual inhibiting factors. Then obviously we set goals and timeline that we are trying to achieve those goals. And once when we start treatment and we sort of decide on the goals, we really look at, first of all, education. So we try to, in a simple terms, educate the patients where the pain are coming from, why the pain is still there, regardless that the cause of pain is removed, like endometriosis lesion. And so we look at the pelvic floor. Sorry, just 1 second. I do apologize. So we educate the patient of to try to understand to make sense of underlying pain mechanism that helps. Once when they understand that, when patients understand that, it really helps reducing that constant fear and threat of experience. And also, if there is a pain, there is no need to think that there is a new damage or new tissue or new endometriosis happening. So in a way, helping patient to sort of try and forget that what happened before. So we do education on basic pelvic floor muscles and its function. We try to understand the complexity of nature of this of the problem. We discuss dyspareunia and looking at additional contributing factors to it, psychological, cultural, social. We then work on trigger and myofascial release, mobilization, scar tissue mobilization, abdominal wall release. And then obviously we gave tools to the patient to carry on with all this self sort of management in a way of trigger point, stretches, release to carry on at home, and different exercises. We use different techniques to release pelvic floor tension, and I have to put accent of it that we don't do Kegels, we don't do squeeze, we don't do 100 repetitions a day, because that's not something that you need in this scenario of pelvic floor sort of function. We encourage very much breathing and visualization. We work on external core and hip muscles, balancing, achieving movement and postural control. We also use some kind of electrotherapy like Indiba active. It's something that is used very much for its radio frequency. It accelerates the healing, reduces pain and inflammation, and prevents scar formation. And obviously we use either biofeedback or electrical muscle stimulation, depending on pelvic floor muscles. In this case, we use biofeedback. Biofeedback is just really reference point for patient to understand what's happening with the muscle, and also to sort of make that a body-mind connection and work on neuromuscular reprogramming, working on activation of the muscle and learning how to relax. So all the above is general guideline, really, that pelvic health physiotherapy would follow for patient for post-surgery. However, each treatment is specific and individual depending on patient's history, social and cultural background, and lifestyle. It's fair to say that one of most prominent symptoms of endometriosis is dyspareunia, which gets better but doesn't just diminish after surgery. It is safe to say that treating dyspareunia and sexual function in women with endometriosis often requires not only multidisciplinary approach, but also time and understanding. Working on visible and current issues such as hypertonic pelvic floor and issues with within pelvic muscles are just part of deeper understanding and issues that women develop during the years. The study shows that patients with endometriosis are at risk of functional sexual disorder and suffer not only from dyspareunia, but all domains of sexual function. Thank you very much. I know I read that very quickly, but hopefully you got something, and then I'm happy to sort of talk about anything further if there is need for that. Thank you.
Mr. Raza, you're muted.
Thank you very much, Liliana, for this very fruitful talk. I'll move the baton to Miti. Miti works with me very closely in terms of endometriosis and dyspareunia. Miti, take it away and tell us more about your own experience and how you deal with this situation.
Fabulous. Okay, thank you again. Thank you, Mr. Raza and Liliana. I think there was a great talk, Mr. Raza, about sort of what happens with endometriosis. And Liliana, thank you for explaining what we sort of do with physiotherapy. So so I work, as Mr. Raza said, I work with him very closely at Amer Health, and I see these patients on outpatient appointment basis. So again, I would do a subjective objective assessment, just like Liliana mentioned. But I think one thing I would like to add today is I come bearing some props, and I would like to sort of, just get you oriented with where these muscles are. And just if there was one thing that you could get started with and do is how to identify your pelvic floor muscles and how to exercise them correctly. And it's not all about the squeezing. So let's just go through where these muscles are first. So this is looking at your pelvis. So this is the bone that kind of sits just around, your I'll just kind of stand up and show it if you can see. So it's just the muscle, the bone that sits around here, okay? So you've got your pubic bone in the front there, and you've got your tailbone coccyx at the back there. So this bit of muscle that you see that sits between these two bones is your pelvic floor muscles. So you've got, if you look at it, you've got the clitoris at the top there, you've got the urethra where you pee from, the vagina in the middle, that's your perineal body or the perineum, and that's your back passage. So as you can see, these muscles, they support three very important organs. And you can't really see very clearly, but I'll try and see. So right at the front, you've got your bladder at the front there, which opens up into the urethra where you pee from. You've got your womb in the middle, which opens up into your vagina. And you've got your rectum right at the back there, which opens up into your back passage. So these muscles, they not only support these three organs, but the exits are through the pelvic floor as well. So they may help you maintain continence. And the third function of the pelvic floor, excuse me, is the sexual function. So it's really important that these muscles are working fine in order for all the three functions to be working fine. Another thing I would really like to mention is that if you think of your pelvic floor, there's actually three layers of muscles. So your superficial layer has functional and fascial connections to your adductor muscles, which is the inner muscles of your thighs. Let me see if I can show you. So it's kind of these muscles here. Your second layer has functional fascial connections to your abdominal muscles. And your third layer is the layer that kind of sits under your bladder neck. Now, as Mr. Raza mentioned, if you remember from his talk, he mentioned about sort of, the nerve sensitization, the pelvic floor muscle spasm. And Liliana also mentioned, we're kind of looking for doing an objective assessment. So we're doing an internal vaginal examination. We're checking for this muscle, how they function. Are you able to squeeze? Are you able to relax? And as Mr. Raza said, there's a bit of a protective reflex in these muscles. So you go into a bit of a spasm, a guarding reflex. And that is essentially what we might find with the patients, and which is why it's very important to work on it's very important to relax these muscles. So it's not all about the squeezing. It's not all about sort of strength training, because one of the things that when I say, do your pelvic floor, the first thing that comes to mind is let's squeeze it all in. Let's start with sort of, sucking it all in, holding it all up. And this is not necessarily sort of, conducive to what we might be trying to achieve with a patient that has that muscle spasm, that has that overactivity, that has pain and discomfort, because squeezing it is probably going to just, make things a little bit worse. So what we suggest is that you start with is just doing some gentle sort of, diaphragmatic breathing exercises. And what that does is it helps you relax your pelvic floor. So I'm actually going to share my screen, and I'll just, before I sort of, get you all doing it with me, I'll show you what you are actually doing. So give me 1 second. Okay, can you see my screen?
Yep, we can.
Fantastic. It's kind of showing a few images. I'm not sure why that is the case. Give me 1 second. Ooh.
You go into presentation mode, maybe that will be fine.
Yeah, it's actually just an image. 1 second. Hang on, I'm just going to stop sharing for 1 second. Sorry about this. I'm actually just going to find this image online. Give me 1 second. I'm not sure why it's doing this. It was
Even
working
in multiple picture doesn't matter. You can just go through it.
It's actually a really good GIF image, and I would like to show it as a GIF image because that will just make a little bit more sense. Now, I'm just going to go directly on to the website if I can. There you go. That's better. Right, I've lost you now. 1 second. Ah, found you. Okay, share, take 2, and this will hopefully work. You are probably now just seeing a lot of you, but now can you see my screen?
Not yet, but we see lots of screens. So I think if you go into presentation mode, maybe we'll be able to see.
Yeah, okay, I think I might just leave it. Okay, I might just explain this to you, okay? So if you think of your core muscles, you've got your tummy muscles in the front, okay? At the top sits your diaphragm. At the back sits your back muscles, and at the bottom sits your pelvic floor muscles. So that's sort of the core muscles that Liliana was referring to, and those are the muscles we kind of focus on. So your diaphragm, which is your main breathing muscle that kind of sits here, works in synergy with your pelvic floor. So when you take a nice deep diaphragmatic breath, basically your diaphragm descends, which has that automatic dropping, relaxing effect on your pelvic floor. So deep breathing exercises, which is deep diaphragmatic or deep abdominal breathing exercises, helps you relax that pelvic floor muscle. So that guarding that is there, we're kind of trying to work on that synergy better. We're trying to help you relax those muscles better. And that is something that I'm going to suggest we have a little go at today. The other benefit that, deep breathing has is we know that taking nice deep diaphragmatic breath not only helps you relax your pelvic floor, but it also helps you bring down the cortisol levels. And especially with someone, who's been having that persistent pain, who's probably in that sympathetic stage, that fight or flight response, if your muscles are in that state, the whole idea of physiotherapy is kind of, pushing you first into that parasympathetic stage to kind of get you more into that rest digest or rest repose stage that we say, and kind of start the treatment from there. So you're sort of much more in a better position to kind of respond to that treatment. So what I'm going to suggest is, and Mr. Raza, Liliana, please feel free to join in as well, is let's start with having one hand on your chest and one hand on your belly. I'll just show you what I'm doing. So there. Okay, so you want to start with taking a nice deep breath into your belly. So the first thing you want to do is, so if I was to say take a nice deep breath, what I don't want to see is your hand on the chest moving. So what I don't want you to do is, because that to me is you using your accessory muscles. Okay, so we're going to start with taking a nice deep breath into your belly. So as you breathe in, your belly rises. And as you breathe out, your belly falls back down again. I'm actually going to stand and show, stand and show you my chair so actually you can see me a little bit better. Okay, so nice breath in. As you breathe in, your belly rises. And as you breathe out, let your belly fall back down again. Okay, let's try that again. Breathe in, belly rises. Breathe out, belly falls back down again. With the next breath in, as your belly is rising, imagine that pubic bone moving away from your tailbone. So breathe in, belly rises, drop and relax that pelvic floor, or imagine that pubic bone moving away from your tailbone. And as you breathe out, it all comes back in again. So let's just have a go at doing that a couple more times, and then we'll kind of pause for a question, okay? So again, let's do that. Nice breath in as you breathe in, belly rises. Imagine dropping your pelvic floor. And as you breathe out, belly falls back down again. One last time. Breathe in, belly rises. Drop and relax that pelvic floor. Breathe out, belly falls back down again. So we're just going to pause here for a second, and I'm just going to ask Mr. Raza and Liliana, you can ask questions as well, is can you feel anything happening in your pelvic floor? And if you don't, do not worry. This is just a very sort of basic exercise we suggest get starting with, along with perhaps maybe also doing some stretches that, Liliana mentioned before, is, you have these muscles that connect into your pelvis. So we want you to do some gentle stretching exercises like, the happy baby, which helps you relax that pelvic floor muscles, the child pose. All of these exercises, they help you release the muscles, the adductor, the inside of the thigh, your pelvic floor muscles. And this is kind of what we suggest that you start with, along with something you can kind of start with while you're waiting to see the physios, or, waiting for your surgery, etc. So any questions on just the breathing exercise? Let's start with that first, and then we can kind of open the floor up to questions, more questions.
For me, I think when we try not to use our accessory muscles, we see the pelvic floor going down. So maybe it causes more relaxation. And you're right, actually, when we say pelvic floor exercises, the first thing comes to mind that we have to stretch and pull everything upward. But that's, you're saying, is not the right thing. That's not the pelvic floor exercises.
As in, yes, ideally what we want is the pelvic floor muscles to be able to fully relax, and when you're squeezing them, to be able to kind of work from that relaxed position to that, that squeeze position. But if your muscles are, say, tightened, shortened, in spasm because of pain, if you were to then do some more squeezes, you're not really helping that situation, and that is not essentially what we're trying to achieve with these patients. We want to release the muscles, relax the muscles, and help increase the blood supply to the area, help desensitize the nerves, the sensitivity, and sort of work on those muscles from that position.
And in my opinion, it's actually the most difficult part of the treatment, sort of getting first breathing right, and that relation, and also really that neuromuscular programming in between brain, synchronization in between muscle and brain, and also trying to, in majority of cases, trying actually for people to visualize, and regardless of explaining the various pelvic floor and everything, it's very difficult for people to connect with it. So I feel that always in first and second session, it's just important once that the awareness is raised, and sort of we do different visualization and cues. And so once when that muscle is finally found and kind of able to activate and therefore relax, that's kind of first step. And even with people who use dilators and different things, it's still very important to find that connection, because otherwise that muscle memory is never going to be formed. And so it's very difficult to kind of progress and work further on different issues. So, yeah, one of most important things, starting with breathing. And I usually start with sort of further away distal sort of parts, and massaging inner thigh and working on a pubic area, and sort of trying to improve circulation, trying to sort of again relax the areas around, and then we come to that. So kind of that's in my opinion how it works.
So maybe if I ask you a question, when a patient first presents with painful intercourse, what assessments do you perform to distinguish between pelvic floor dysfunction, neuropathic pain, and pain coming from the endometriosis? A brief answer, if you can give it, just a general examination.
Sure. So I usually, when a patient comes with me, I'll start with a subjective assessment. So I would certainly want to understand what are the main complaints, how long has it been going on for, just a basic history of, present complaints, history of present complaints. But then I go into more details, like what is your bladder function like? What is your bowel function like? So I'll go into a lot of questions about the bladder, the frequency, any, symptoms they might be having, urgency, incontinence, any problems with any difficulty voiding, any difficulty initiating, any pain passing urine, all of that. So that gives me a very good idea of what's happening or what may be happening. I also go into questions about the bowels as well. So I really do want to know about the bowel function. Are they constipated? Have they got any obstructed defecation? Have they got any difficulty with opening their bowels? What the consistency is like, and what's the frequency like, etc. I then go into more questions about the sexual function as well. So again, is it pain with penetration? Is it painful with more sort of, deeper penetration? Is there any pain with orgasm? Is there any pain with certain positions, etc.? And again, the type of pain that they're getting, how long does it last for, etc. And I then want to know everything about sort of their gynecological history, their obstetric history, just to see what's happening with the periods, the pattern, things like, is tampon insertion painful, or do you wear pads? And just that, again, gives me a really good idea of what is happening. And of course, their past medical history, their medications, their surgical history, and then also quite important to understand what their social history is like. Are they in a relationship? Are they working? Does certain positions, is there any provoked pain, unprovoked pain, activities? What's limiting their quality of life? So I will first try and I spend a really good sort of, 30, 40 minutes just trying to get that subjective history. And then the next sort of chunk of the session I will spend on doing is an objective assessment, and that is where I will obviously, with patient consent, do a vaginal examination, a rectal if required as well, but usually I will do a vaginal examination, and I will then check for everything from like the tissue superficially, the pelvic floor muscles superficially, to doing more internal assessment as well. I may or may not use a speculum. Again, I may or may not use an ultrasound, like diagnostic ultrasound, just to see what's sort of happening. It's fantastic for visualization. It's great for biofeedback. You can show the patient exactly, if they're not squeezed, if they're not relaxing, then it's very good to say, well, look, this is what your muscle's doing, etc. So I would make that as part of my sort of assessment as well. But I definitely would do a internal with finger and gloves as well, because that's when you get the tone, because that's one thing you can't check in an ultrasound machine, but you can get everything else. And it's great visualization for patients as well who've got a bit of a disconnect, have never seen what the muscles do and can feel like. And I would also then, if needed, do a sort of a rough, brief musculoskeletal assessment, and I will use things like just a basic hip assessment, spine if needed, etc. So whatever I think might be needed based on the history, I will do that before I then kind of go into the more treatment side of things. And I think that's what will help me understand what or where it's coming from.
Excellent, very good. Okay, I can keep asking questions from both of you actually, but before I do that, I think I'll ask if any of the audience want to ask any question. Hattie, are there any questions for me too?
Yes, we have quite a few questions in the
Q&A
section.
Let's do it. Q&A session. Okay, that's right. So I'll go and open the Q&A session. That's right. Okay, I'm starting right from the top now, and whoever wants to go. Can using dilator help with pain during sex? That's the question to Mitty first, and then Liliana.
Can using dilator, what was the whole thing? Sorry.
Help with pain during sex. Can help with dyspareunia.
Sure. So again, depending on the assessment, depending on what we find with the muscles, if there is any muscle overactivity, then dilators are a good tool to have. Usually I tend to use the dilators. I limit them to more sort of vaginismus patients. For more deep dyspareunia patients, I tend to use a TheraWand, which is much better because it helps me sort of go further, more deeper into the muscles that I want, like more targeted therapy. But dilators is great for someone that does have vaginismus, where you're then, gradually sort of, almost sort of grading, you're gradually increasing the size. So that's kind of what I reserve it for, really. But otherwise, I would use a TheraWand to kind of work on the muscles, which you most likely might not be able to reach with your thumb, especially if it's deep dyspareunia. And then I would work on the muscles there and get you using that to help relax the muscles and work with it. So I'll teach the patients how to use it, and then I'll give them a home exercise program to do it, at least 2 or 3 times a week, and apart from sort of seeing me as well.
That's wonderful.
And also, actually, one more thing I wanted to add is vibration also has vibration has much more sedative effect on nerve endings compared to dilatation. So depending on, again, if girth is a problem, not a problem, etc., depending on what bit of the muscle I'm treating, I might bring in vibration as well. And again, with the dilator therapy or TheraWand or vibration therapy, it is something that can use sort of, alongside with your partner as well. So it's all sort of, progressions that I would do.
Liliana, yes, you want to add something?
Yeah, same. Yeah, absolutely. I do believe in dilators, but I think also that sort of active sort of participation of it. I feel that dilators are more of a passive treatment, and yes, they do. I think that also grading them, starting with small one, unless you are doing thrusting, and I feel that they are not having long-lasting effect. And I had quite a few patients who would go to size 3 or 4, and actually after a month of different situations and stress, and really go back to size 1 and still have difficulties. And so I would sort of recommend them and use them in a proper way. But at the same time, I believe that sort of partner or self stretches and perineal stretches, vaginal stretches, and then different relaxation techniques that would kind of in connection with dilators work much better rather than just dilators itself.
Thank you. Okay, Liliana, question to you this time. Are there any exercises you recommend to help with pelvic pain? And I have heard Pilates is good. What is your take on this?
Any exercises, sorry, I didn't understand, but any exercises that will help pelvic pain?
Yes.
Is that what you're saying?
Yes.
Okay.
Yes.
So I basically, first of all, with patients who come, as we are talking about these patients, I don't really ever suggest working on so many, as I said earlier on, like no Kegel, and not really, I don't use verb squeeze, I use verb lift, because I really think that visualizing and what people are doing with pelvic floor makes up. If you are using squeeze, I think that people always tend to do superficial layers more than deeper layers. So I always try to form exercises in terms of more stretches with relaxation rather than strengthening. And in a way, these muscles, when you examine them, they're already very tight, and you really want them to start functioning. So in order to start functioning, they need length. So basically, you need to stretch them, you need to relax them and stretch them. So all my exercises, home exercise program and exercises for that are based on more relaxation rather than, but obviously to relax something, you have to activate something. So you need that recognition where the muscles are, breathing and everything, but then it comes to stretches and relaxation.
So
just to add to that, oh, sorry. Yes. I was just going to say absolutely length before strength. So I would suggest we work on that bit first, but ultimately you do need strength, because
you do need strengthening, of course.
Exactly. What you don't want is the muscles to then, you've kind of worked on the length, great, fantastic, everything's releasing well, and then they continue with carry on with the day, and then, there might be, like, again, the tightnesses again, weaknesses again, because, a tight muscle probably has underlying weakness. So it's just making sure that you're then progressing to doing the strength training to maintain everything. So yeah, just to add. Thank you.
So Mitty, another question is, interesting question, is there any advice on how my partner can support me? How my partner can support me?
I think I was just going to say, I think it certainly is a good idea to bring your partner to the session as well with you, because then as a physio, we can work with the two of you as a couple and sort of what your goals might be, and work something that is sort of, mutually sort of works between the three of us, i.e. you with your partner and then me as your therapist. And that certainly is one way of doing it. It's also good to kind of have that discussion with the partner as well. I think that communication is so important, and understanding where you're coming from. So that certainly helps support things as well. And then obviously some of the strategies that I do in terms of progression, I will usually bring I usually start bringing the partner in after a certain point, because initially I don't, because for example, to give you an example, if you were using a TheraBond or a dilator or a vibrator with your partner, your muscles are going to react slightly different to when you're doing it by yourself to compared to when your partner is doing it, because your brain knows that you're not any threat to yourself. You're not going to damage yourself, but when someone else does it, it might feel there'll be a little bit of more guarding there. So I usually, when I'm trying to kind of wean them off the whole medical sort of, model of, okay, I'm using a dilator, I'm using a vibrator, I then start bringing the partner in to kind of, take it away from that model. And I think it's a good time to then bring your partner in and start having that session.
So I will ask a question from Liliana. I didn't receive physio support after excision surgery, endometriosis excision surgery. Is it important? Should I get some now?
Yeah, I think even if there are no any pains, or if there are no any issues, I think it's always useful to see someone and basically be advised on progression, on exercises, on different things. There is so much to talk about, and especially if there are some sort of complaints regarding bladder or bowel or whatever, I think it's always useful to see someone, even just for one session, and get some advice on how to lead into the future.
That's very helpful. And yes, in my practice as well, when I see patients and do the surgery for excisional surgery for endometriosis, I will ask them about pelvic floor exercises. I will ask them to go and see a physiotherapist, a routine practice. And if they have an element of dyspareunia, then even most important, that I will tell them my surgery has done, but it won't sort out the problem of dyspareunia, painful intercourse. You have to go and see a physiotherapist. A wonderful team in Cromwell Hospital. They go and see them, and then Mitty sees them in Awara. So we really work with this very important topic all the way through. Okay, next question.
Just to add to that, I was just going to say, because as you very correctly said, the surgery might not necessarily, sort of treat the muscles. You're taking the, you're excising the adhesions, etc. But if your muscles have gone into a bit of a spasm, that pain is going to cause more spasm, is going to cause more pain. So you end up in a pain spasm vicious cycle. And even if the trigger is gone, you're still you're stuck in that cycle. To break that cycle is where we physios come in, and then we help with sort of, everything from like the strategies to relax down training, wand, etc., whatever's needed to help break that cycle, to help increase, make the muscles, work on the length, increase the blood supply, and that is when you get relief from the symptoms. And
right,
yeah,
and that is nice to the next question. Now we're coming close to the finish time as well. Should I still be experiencing pain during sex even after excision surgery? What can I do to reduce the pain? So Mitty, go ahead with it, and then Liliana.
I think pretty much what we touched on is the reason you're still getting pain is because despite that the triggers may have been gone, your muscles have been in a state of spasm for a long time, which is causing pain, which is causing more spasm, which is you're ended up in that vicious cycle. So I think coming to a physio, having an assessment, working on that muscle is what's going to then help with rehabilitating you back to having pain-free sex.
Yeah, exactly. It's breaking that fear, breaking that threat, and that memory of, oh, it used to be painful, and it's really that guarding that needs to be kind of stopped. And that's also is worth mentioning that it's a process. It doesn't happen. I think if people have expectation that after one session it will all again be gone and brilliant, unfortunately it doesn't work that way. And the longer situation that led to this was, the longer it will take to get back to kind of normal tone of the muscle, and therefore no pain. And at the same time working on that psychosocial sort of part of it, and trying to break the pattern and circle. So
okay, that takes us to possibly our last question now. What outcome measures do you use, and how do you measure success? Anyone?
So the first thing is, like, when we do internal examination, obviously we use the sort of scaling. We have a power scaling of the strength of the muscles, endurance, repetition, and this. So obviously when we reassess that, that's one sort of way. Then we measure and we look at the function of the muscle, which again, that's sort of objective measure. And we use these functional scales in a way of like, okay, what is your most difficult problem? It's sort of penetration during the sex. What is it on the scale of 0 to 10? And then we reassess that later on. And then with some people, we use a quality of life questionnaire. So the scoring obviously shows, is there any improvement or not after a couple of sessions? So those are things that I use actually in our practice.
Any comments, Mitty?
I was just going to say, yes, I would probably use some prompts like the Australian pelvic floor questionnaire, depending on what symptoms they might have, or any
Depend on the
specific,
symptoms, exactly.
depending on the symptoms, I would, or, you know, any pain scales, but yes.
Okay, excellent. I think we've gone through almost all the questions now. So I will just say, Mehti, you want to add something, but thank you very much, Liana. Thank you very much, Mehti. It is a topic we don't talk much about it. We talk about all the bowels and everything, but I thought that we should bring in intimacy and deep dyspnea. It is such a personal issue, and we should bring it absolutely in the open and talk about it. I'm sure Hetty will tell us this webinar will be available to people later on as well. But thank you for coming. Thank you for joining us as well. Thank you for everybody on Thursday evening to come and join us so late. So many people. Very kind of you, and look forward to see you all in our next webinar in 2026. Yes, Hetty. Thank you.
Thank you.
Thank you so much to our wonderful panel. There's some information up should you need it, and in the chat function. Thank you again for all your insights. A really important topic that's not much spoken about. You can find more information on upcoming events on our website, cromwellhospital.com/events, including past recordings from other events talking about things like fertility and endometriosis and bowel and things like that. And we hope to welcome you to more in 2026. But just a very big thank you from Cromwell Hospital to our wonderful panel today, and thank you everyone for joining us.
Thank you.
Thank you.
Thanks. Bye, everyone. Mehti, can I contact you at some point?
Yeah, sure. Absolutely.
Of course, yeah.
Absolutely.
Just to discuss few